Okay. So we have a 74-year-old man who reported 2 to 3 weeks of gradual vision loss in the right eye. He was seen by an outside ophthalmologist who saw macular swelling and injected the Vizno. He's been on chemotherapy, carboplatin, hypoxia capsule for 2 cancers. So his medical history is significant for metastatic prostate cancer and squamous lung cancer, for which he's had like surgery, radiation, he's been on chemo and other kind of relevant medication.
He's a medical doctor now, but it makes a big difference, but just don't ask him.
His vision is 125 in both eyes, and his pressures are normal in both eyes.
Sorry, can you just go back to the surgical?
Mm-hmm.
So it said craniac. Cool. Okay. The vision's the same in both eyes?
Mm-hmm.
Okay, so fundus photo, the right eye, media is clear, nerve looks okay, the vessels are good. Attention is drawn to the spot in the inferior nasal macula, some hyperpigmentation, lesion right there. Everything else looks okay. Maybe this vessel is a little engorged.
I think he's got a cataract. Does he have a cataract?
I'm not sure.
I think he does. I think the view is not great, but he's a cataract.
Okay. Left eye, fundus photo, media is clear, nerve. It's like there might be some increased cupping there, like a 0.8 cup, maybe a little temporal pallor along with some PPA. I also think there's some abnormal hypopigmentation or lack of pigmentation in the macula, but I wouldn't be too impressed with it. So this is a OCT of the right eye. Grainy photo, so maybe there is a cataract. But attention is just drawn to the significant amount of probably hard to tell if it's intraretinal or subretinal, but just a lot of retinal
I
fluid.
think it's intraretinal.
A large amount of intraretinal fluid. Don't see much choriocapillaris, but it could just be the quality of the photo.
It looks about the right, it is a craggy photo, but it looks about the right thickness. It's like probably there. And then you can see the outer retinal layers there, kind of. You lose them here because of just the quality of the sigma. I think we have 4 sigma on this one, or something.
I know there are some like cystic spaces, maybe a little bit near the outer retinal area.
Yeah, it's the same eye.
Same eye vertical cut. Same findings. Left eye, challenging quality, but it looks okay.
It's a little cystic. Like
This face?
Yeah.
Okay.
I think, I mean, the inner nuclear, yeah.
Probably a vertical cut of the left eye. Maybe a little disruption of the foveal contour, trace ERM. I'm not really seeing any significant fluid. All right. So macular thickness, 5 something thick number, so probably high. Okay, so we have FA, the image on our, well, it's a right eye, image on our left is on the laminar phase, not seeing too much pathology. The image on the right is probably a late phase, and again, don't see any pathology.
Right, you can see it 25 seconds and 4 minutes.
Yeah. Okay. All right, FA at the left eye, same findings. Maybe, well, the PPA that we saw earlier.
So to summarize, we have a 74-year-old male with extensive cancer history who underwent various treatments, including chemotherapy. He presented with gradual right eye vision loss. The imaging, the findings are a little bit more notable in the right than the left. On the color fundus photo, he had what I thought was like a blunted foveal reflex, the hyperpigmented areas, and then separately the enlarged cup to disc ratio. On the OCT macula of the right eye, there was like significant loss of the foveal contour. I thought it was subretinal fluid, but I guess intraretinal
He
fluid.
doesn't, hard to tell. Those are-
And then.
I think it's cataract, I should have put that in straight, I'm pretty sure it's cataract's pretty thick, so some of the vision loss is cataract.
And then the intraretinal kind of hyperreflective cystic areas. And on the FA, no obvious like leakage of vessels or like around the nerve, I thought. And so what are your differential?
So there's the hyperpigmented lesion, of course, could be choroidal nevus, but given his extensive cancer history, would certainly be concerned about metastatic lesion. Didn't really have any vascular pathology history, so we wouldn't think diabetic macular edema or anything like that. So I don't know if there's, probably is, you can get macular edema with chemotherapy drugs, chemotherapy drug associated macular edema.
And then for differential, there's another thing about the findings, if you go back, so there's macular edema, but the fluorescein didn't show any leakage.
Mhm.
So do you know, that's like a list, do you remember that one?
Mhm.
We wanna-
Fishing. You're right.
There's that list of macular edema without leakage on fluorescein. I think you guys have to know.
Epinephrine induced. Another crowd there, where most of it though.
I think different.
I remember some, do you have it?
I'll go over it.
So go over it, okay. I
Okay,
just
so
remember nicotinic, I
I
remember
didn't-
nicotinic acid, niacin and a couple others.
So I divided the differentials based on like the CME with leakage on FA versus CME without leakage. So you can use a mnemonic, I think, deprivins to kind of recall like the risk factors for CME with leakage on FA. So we have DME, epinephrine, any type of uveitis, most notably parsplinitis. And then RP, I saw can present with or without leakage. So I denoted that with an asterisk. Irvine gas syndrome, BRVO within BRVOs, again, nicotinic acid and niacin, can present in both, with leakage and without leakage. And then any type of surgery that causes like inflammation or disrupts the retinal blood flow, can cause CME with leakage. Additionally, we have like tractional components like vitreomacular traction or ERMs. And then I think latanoprost is something that's like noted pretty frequently as causing CME.
Yeah.
As well as diabetic medications. And then so with CME without leakage on FA, I think there are a list of like retinal dystrophies, like X-linked juvenile retinoschisis, Goldman-Faber syndrome, Fabry. RP and nicotinic acid again can present with or without leakage, and then taxanes, which are the chemotherapeutic agents our patient was on paclitaxel. And then I also read about like kind of systemic disorders like multiple myeloma and Waldenström that can cause CME without leakage because it causes like a hyperviscosity syndrome in like the serum, and it changes the osmotic gradient somehow. So I saw a couple of cases of that. Okay, so for our patient who had extensive cancer history, he was started on paclitaxel and carboplatin a couple of months ago and developed possible macular edema from these drugs. And then about 6 months later, those were stopped. And so,
After he finished, so we didn't prematurely stop it, he just finished his course.
and then, so this is like a good overview of like the patient when he initially presented, I think referred to Dr. Cohen's office in that top left, with the macular edema. And then he completed his chemo in that bottom kind of left, after that bottom left, kind of visit. And then subsequently you can see the resolution or significant improvement in the macular edema in that last image. And then similar kind of findings for the left eye. And then this is the OCT macula of the right eye at that last visit with kind of complete resolution of the significant fluid. He has some residual kind of cystic cases there on the fovea. And so CME refers to kind of the macular thickening and cystic changes due to the accumulation of fluid in either the extracellular spaces, which is known as vasogenic edema, due to breakdown of the blood-retinal barrier. And this can be in the setting of things like ischemia, inflammation, vascular disorders, and this causes leakage from the hyperpermeable retinal capillaries. Fluid can also accumulate in the intracellular spaces due to cytotoxic edema and Mueller cell swelling, again with the changes in the osmotic gradient. And so in a normal kind of healthy retina, kind of fluid is removed from the outer and inner retinal layers by the RPE and Mueller cell respectively. And so, as you would expect, patients might report kind of decreased or blurred vision, distortions, micropsia, central scotomas, and you would also see like a blunted foveal reflex if there's clinically significant kind of foveal edema with a thickness greater than 300 microns. And then you may also see optic nerve edema as well as vitritis in certain cases. OCT findings again include the diffuse retinal thickening, the intraretinal hyperreflective cystic spaces, prominently in the outer plexiform layer, varying degrees of subretinal fluid, and then also some of the attractional components like an ERI.
Adult inpatient 9A2.
On FA,
Code gold, adult inpatient 9 alpha 2.
you would see like the parafoveal capillary dilation in the early phase. And then in the late phase, you may see leakage or pooling in a petaloid or flower-like pattern. And this is because of the radial distribution of Henle's layer around the fovea. And then you may also see late leakage of the optic disc. And I think this is more common in pseudophakic CME and also CME caused by uveitis.
It's a nice way to differentiate. And if Dr. Payman, are you on? Did you write a paper? I always reference a paper that I always thought that you had written on this, but so if you're looking at somebody with macular swelling and they have macular pucker and they've had recent cataract surgery, you're like, oh, is it the pucker or is it the cataract surgery? The thing to look at is actually the nerve. So what's going to happen is your macula is going to light up on both, but if the nerve lights up, then it's probably a fair amount of pseudophakia. You just do that. Steroids or shots or whatever. And if it's the nerve doesn't light up, it's probably the macular pucker. I still try drops, but you're more likely to need macular pucker surgery. But either way, are we there? Yes.
I'm here. So I can't show my face. I can't figure out. Oh, here we go. You should be able to see me now.
We can't see it because the screen's all the presentation, but I'm sure you're looking good.
Yeah. Oh, that's all right. Listen. I presented something at Arvo years and years ago. We're probably talking 35, 40 years ago. And, but I never published it.
Okay, that's what I thought, unpublished paper. Okay.
Yeah, well, an unpublished study. But in his original paper, Dr. Gass, when he first described fluorescein angiography, the case was cystoid macular edema, and he noted in that original paper that there was also staining of the disc. So
Cancel code gold, adult inpatient 9A2. Cancel code gold, adult inpatient 9 alpha 2.
So he was he was obviously pretty brilliant. I mean, he got it in the original paper describing fluorescein angiography right off the bat. So it's just I am so grateful that there's so many people around, so much smarter than I am. It's really good.
Thank you. So yeah, so I always look at the nerve and the macula, and it's helpful for differentiating whether it's inflammatory or just something going on with the macula.
Can I tell you a story? Just
Absolutely.
an old duffer story.
Sure.
So I have seen Roth spots up the wazoo, and I have never seen subacute bacterial endocarditis, and it is one of the great disappointments of my life that I never was able to pick up on it. But I had a similar experience studying syphilis in medical school, and I always wanted to have an acute case of syphilis, and there was a case on another ward, but I ended up in Cleveland, and I kept on looking for this. And one of the classics of secondary syphilis is you get acute spots on your palms. It's very distinguishing. So one day I came to clinic, and the nurses said, "There's a woman in there with a rash," and I got all excited because I was thinking maybe this was finally my syphilis case. And I went into the room and I looked at her and I said, "Show me your palms." And she showed me her palms, and there was the rash. I was so thrilled. And I said, "You've got syphilis." And I was so happy. But somehow she wasn't, and I never understood why. But I finally got my case acute secondary syphilis to this day. For more than
Yeah, I
40
have a
years
bucket
later,
list.
I have
I
not
haven't-
forgotten that woman.
I've never seen an acute VKH. I just never have. I don't know why. You know, I don't think it's that rare. I just haven't seen it.
So anyway,
All right, thanks.
old Duffer story.
I haven't had
Comic
bacterial on the plane either.
Comic relief, I hope.
Thank you.
Okay, so, pivoting back to our patient, who was on paclitaxel, which is a taxane drug or an antimitotic drug that, binds to like the microtubule network, ultimately just causing apoptosis or cell death. It has a known side effect of causing CME without leakage or angiographically silent macular edema. And so the classic kind of presentation is the bilateral CME with the cystic spaces on OCT, little to no leakage on FA. And the exact mechanism is not known, but it's believed that RPE and Mueller cell dysfunction or toxicity because of the microtubule disruption causes the fluid accumulation without significant vascular leakage. And this can be kind of reversed or improved with stopping the medication or with dose reduction. And in refractory cases, you can use carbonic anhydrase inhibitors, or either like topical or systemic with.
Code gray, 6C1, code gray, 6 Charlie 1.
So I'll just say like, you know, in treating CME in general, I think it's typically a self-limiting process, but there are a variety of therapeutic agents. I think NSAIDs and steroids are like the ones that we commonly use first line, and they inhibit the prostaglandin production. The carbonic anhydrase inhibitors, which are effective in cases like ours with the taxane-related macular edema, but also in CME caused by like RP. There are anti-VEGF agents, and then also vitriolytic agents, which I'm not sure how often that's used in the clinical setting, but
I don't think they're on the market anymore.
okay.
But yeah, it's interesting that when you review this, all the literature evidence stacks up for NSAIDs. So every paper that's out there says that the most effective thing is NSAIDs. But in clinic, I swear it's steroids are more effective. You know, so most of us use both. And I read where they're synergistic. And the other thing about steroids is the root's kind of interesting. I always thought, I love subtenon's Kenalog. It costs about $10. You know, the risk of harm is extremely low. You get a little ptosis sometimes, but you're not poking the eye, and it lasts for 3 to 6 months. It's very safe. So I do subtenon's Kenalog constantly. And I always thought it was just as good as intraocular. And I had a woman with refractory CME to subtenon's Kenalog. And so I did one shot in both eyes, subtenon Kenalog. It didn't budge, which you don't see that much. And so I thought, I've always been curious. So I said, "Do you mind if I treat your eyes differently?" So I gave one of her eyes a second shot of subtenon's Kenalog, and I gave her other eye an intravitreal Ozurdex. And the Ozurdex just nailed it. And the subtenons didn't do anything again. And I don't think I missed. You always wonder, like, because it's a blind state, you don't know where the needle exactly is. But I'm pretty good at it, and I think it was in the right place. There's another one now. Is anybody in your clinic doing, I don't even know the name, I feel bad. There's one you can shoot in the suprachoroidal space. It's, I don't do it. The rep, we were in the study and I still don't do it. And the rep comes by, he's like, "Yeah, I know you don't do it." I'm like, "Yeah, I'm sorry. I just don't see the point of it." But it may be a little better. But the idea of sticking a needle in the suprachoroidal space is just weird for me, just for steroids. I mean, if there was something, I think down the road, we might end up doing like gene vectors that way. If there's something you had to do that way, but there's so many ways to give steroids that it just seems a little much.
Yeah, like interestingly, based on like what I was able to read, I think steroids and NSAIDs, based on the limited case studies they had for taxane-related macular edema, they weren't as effective as the carbonic.
Yeah, no, I think, yeah, they're different cases. So like steroids aren't gonna do anything for wet AMD. I mean, there's all different causes. In vein occlusion, I don't think they do anything for it either. So it depends on what the macular edema is coming from. But if it's inflammatory, then the NSAIDs and steroids are good.
And in this case, the anti-VEGF wouldn't have done anything here.
Wouldn't have done anything. And it's, I'll tell you at the end of the, yeah, he was treated, yeah, why don't you finish? I'll tell you that.
So the key takeaways, imaging like FA and OCT are useful in diagnosing CME, but we also have to be aware of causes of CME without leakage on FA or angiographically silent CME, like those caused by, taxanes or other drugs, retinal dystrophies or other systemic disorders. And so, like Dr. Cohen said, identifying the underlying etiology is really important in guiding kind of treatment for CME.
So this case is actually, I think it's being sent into the Board of Medicine as a support for a focused practice designation for retina specialists, because he was treated by a community person who's not a retina specialist and given Vabysmo for wet AMD, which, or just, and I think in fairness, he thought it might be wet AMD, there's macular swelling, Vabysmo always works, why not try it? And we do that sometimes, but I thought this was a little much in this case, and the guy was really suffering. So it's the idea where you kind of need a diagnosis. I'm always like that. I saw a patient from a retina specialist up in Brooksville I really like, who sent down, which is a weird case, and it was central serous. It was your central serous can look really weird, and the patient said that retina specialist was on speakerphone with his ophthalmologist, talking to him about like, why did you treat this with anti-VEGFs? Like, he didn't even know what the diagnosis was. And I said, wow, that's a lot to do on speakerphone. with the patient in the room. But he said, oh, they were friends and we all know each other. So, and things are different in Brooksville. That's how you do that. But no, it's kidding. But anyway, so yeah, it's nice to have a diagnosis. I think it's like really, and the other thing I always harp on in ophthalmology is I think if all you do is the eye, and especially if all you do is the retina, I don't think there's an excuse for not having a diagnosis for people. I mean, everybody's got a diagnosis nowadays. You see, it doesn't matter how weird it is. If you have a case, there's a diagnosis there somewhere. And not just a finding. So CME is a finding. Pseudophakic CME is a diagnosis. CME is a finding. So you should have a diagnosis. All right.